All right. Hi, everybody. Welcome to Talking Data Equity for Friday, December 15th. We made it to December 15th. It is great to see you all. And we have a lot of regular folks back to Talking Data Equity, and we have some new folks today. And we are happy to see you all. My name is Heather Kraus, and I'm the founder of an organization called We All Count. We All Count is a project about learning how to increase the equity that is present in your data projects, your quantitative evidence. And we run Talking Data Equity on Fridays as just an informal, open community gathering that welcomes anybody who is a practitioner working on any kind of project in any sector, in any part of the world, that is interested in finding practical, concrete ways to increase the equity in that project. And we do lots of different things depending on the week. And this week we have a really special guest. So I am very, very excited to be able to introduce you to our special guest in just 1 minute. And right before I do that, I'm just going to do a tiny bit of housekeeping to let you know that yes, we absolutely will be sharing. Oh, somebody brought their otter. We're going to remove your otter. No offense to your otter, but we do ask that if you bring, if you have an AI assistant kind of automatically attached to your Zoom, that you please disable it before you come to Talking Data Equity. If not, we will remove it. Again, it's just kind of the way we do it around here. So, how the logistics work when we're doing Talking Data Equity is that we do record our conversation, and we record the conversation to be able to share it in the We All Count Data Equity community forum. I just shared a link to that forum in the chat. And that's a public good. It's an open space where anybody can ask questions and share resources. And we share the recording from these Talking Data Equity sessions along with resources so that the lots and lots of people who are interested but can't attend at noon on a Friday have a chance to join in with us there. Second, while our special guest is talking, we request that you have as many conversations as you like in the Zoom chat, but that you keep your microphones turned off just while our special guest is sharing her stories and her experiences. Then afterwards, when the storytelling part is over, that's when, if you are live in the room and you want to unmute and ask a question, you'll have a chance to do that there. But in the meantime, don't feel like you can't ask questions or have conversations. You can feel free to use the Zoom chat as much as you like. All right. So with the housekeeping out of the way, let me introduce you to somebody that I am really, really excited has been able to find the time to join us. This is Sujata Joshi. And she has served as the IDA Northwest Project Director at the Northwest Tribal Epidemiology Center, which some of you might know as TEC, for more than 10 years. And her work is amazing. And we're really, really privileged to be able to get an insider's glimpse. She's focused on increasing the quality and accessibility of public health data for tribes in Idaho, Oregon, and Washington. She received her MSPH with a focus in epidemiology and biostatistics from Rollins Hills School of Public Health. And prior to joining the Northwest TEC, she served as an environmental epidemiologist for the state of Oregon and as an epidemiologist at the Intertribal Council for the Arizona TEC. So let me give a very warm welcome and a huge thank you for making time in your busy schedule for sharing your stories with us. Welcome, Sujata.
Thanks so much, Heather, and thank you so much again for the opportunity to join you today. Let me go ahead and share, hopefully, the right screen. Right, so today I wanted to spend some time talking about tribal record linkages and how we've used tribal record linkages to increase the visibility of Northwest tribal communities in public health data. So just a little bit about me, more about me. As Heather mentioned, I've spent about 13 years serving in tribal public health. I've had the honor of serving tribes here in the Pacific Northwest and also in the Southwest. I originally grew up in what's called the Deep South in Alabama and have made my way west since then. And just in my free time, I enjoy reading, kayaking, and spending time with my cats. On a more serious note, I also want to acknowledge that I'm a non-Indigenous person talking about Indigenous data issues. And I recognize that data have been used to both stereotype and harm Indigenous communities in both research and practice settings. So as I'm talking and presenting today, I apologize if anything that I say or how I present information causes harm in any way. And if people are willing to provide feedback, would just appreciate feedback on how to change how I'm framing this information so I can avoid causing harm in the future. I do want to talk a little bit about the organization I work for and the tribes we serve. So the Northwest Portland Area Indian Health Board is a tribally owned organization that was established in 1972. We serve all 43 federally recognized tribes in Idaho, Oregon, and Washington. And you can see a map of all of the tribes that we serve right here on this slide. Each of these slides appoints a delegate to the board that provides oversight for our organization. And that is how they govern the work that we do. Our vision is wellness for the seventh generation, and our guiding values include tribal sovereignty, traditional Indigenous knowledge, and culture as health promotion. The tribes that form our board of delegates own all of the work that we do at their direction. And so to this end, we obtain approval for all our work and all of the funding that supports that work through tribal resolutions through our board of delegates. In addition, we ensure that all of our work aligns with our strategic plan, which is also developed in partnership with our board of delegates. We regularly assess our tribe's public health priorities and needs through surveys, interviews, and input sessions during our tribe's quarterly board meetings, and then use that information to ensure alignment with their priorities and needs. And then lastly, we invite tribes to participate in whatever level they have capacity to do so in our specific projects. So Heather mentioned tribal epidemiology centers. If you're not familiar with tribal epidemiology centers, there are 12 throughout the nation, and our organization houses one of those 12. And tribal epidemiology centers provide epidemiology and public health support to tribes and urban Indian organizations across the US. So this map shows the service areas and locations of those 12 tribal epidemiology centers. And it's important to know that, like tribes, tribal epidemiology centers are considered public health authorities under federal law. So if you're interested in learning more about tribal epicenters, there's a great website that goes into more depth about the services that we provide and also has contact information if you'd like to connect with the TEC in your area. So all of the 12 techs share 7 core functions, but we differ in how we conduct activities under these core functions. So I won't read through each of these core functions in detail, but just want to note that having access to quality data is really central to the implementation of activities under these core functions. So I'd like to go now into spend some time outlining some of the key data needs and challenges we've encountered and work to address here in the Northwest. And I often come back to this quote. So it reads, closing economic and health disparity gaps and addressing program and policy issues is complicated by the invisibility of American Indians and Alaska Natives in their own land. It is not clear if invisibility results from lack of data or if lack of data leads to invisibilities. So that issue of invisibility of Native people and communities and data is a longstanding issue that many Native and Native serving organizations have worked to address over the past several decades. And it's really driven many of the conversations we've had about data here in the Northwest and nationwide as well. And the challenges that tribes experience around data really occur across the data lifecycle. So when it comes to data access, tribal data are housed by multiple entities and agencies, and tribes and organizations that serve them, such as techs, really experience persistent barriers in accessing data that state and federal agencies collect on tribal members. When it comes to data collection, many state and federal surveillance systems just don't collect data in ways that are meaningful for tribes. It's really important to know that many American Indian and Alaska Native people have a political status as members of sovereign nations, and this really isn't reflected in data on race and ethnicity. Even when race or ethnicity data are collected, issues of completeness and accuracy, such as racial misclassification, make data on American Indian and Alaska Native communities unreliable. And lastly, it's often difficult to describe the diversity of experience across American Indian and Alaska Native communities. And this is due to limitations in how data are collected, concerns about small numbers, and also because of legitimate concerns that tribes have about data being reported in ways that are harmful to their communities. So all of these issues taken together ultimately really serve to erode tribe sovereignty, including tribe sovereignty over their data, and make it difficult for tribes to obtain and advocate for resources to close disparity gaps. So I'm going to spend most of this presentation talking about the issue of racial misclassification. So racial misclassification is also called misracialization or misidentification. And it's essentially the incorrect recording of a person's race in a data or surveillance systems. So some of the examples we've seen in the work that we do, so a person who is American Indian might be coded as white on a death certificate. A person who has multiple racial backgrounds, such as American Indian and Black, might only be recorded as Black on a hospital visit record. Or data on a person's racial or ethnic background might not be collected at all and just be recorded as unknown race. So how does misclassification happen? There are a number of ways it can happen. Some of the more common ways we've seen it happen, for one, data collectors or providers either guess at or incorrectly document a person's racial identity. A person might not want to disclose their racial background due to fears of discrimination or stereotyping. A more kind of structural or systematic issue is that data collection systems and practices might not be designed to collect data in ways that reflect a person's identity, and a person might not know how to disclose that in the face of not being able to accurately report or document their identity. And lastly, data on race, ethnicity, and other identities might not be required to be consistently collected or reported. So one of the issues we've noted is that American Indian and Alaska Native communities and people are more likely to be misclassified than any other racial group. And this has been demonstrated in data sets such as cancer registry data sets and medical records. Some of these national studies have found that misclassification rates range between 30 to 70% of American Indian people in the data system. And a national study of death certificates found that 20% of American Indian and Alaska Native records were misclassified over a 20-year period. So the extent of misclassification really varies by data set due to different methods for collecting, confirming, and recording racial information. And misclassification also varies by geographic region. So what we've seen in national studies is that there is lower misclassification in areas with larger American Indian and Alaska Native populations, such as Alaska. and more misclassification in areas where tribal or American Indian communities are more dispersed or less visible. So here in the Northwest, we've been working at the direction of our tribes. We've been working to both assess and address misclassification of American Indian and Alaska Native people since before 1999. And what we found in that time is that misclassification can range from 6% to 100% of American Indian records, depending on which data system you're looking at. So what we've seen in birth and death records is that these systems tend to have relatively low, about 6 to 10% of American Indian records are misclassified. Cancer registries average at about 30% of American Indian and Alaska Native records. And systems such as hospital discharge and communicable disease registries can have upwards of 40 to 60% of American Indian and Alaska Native records missing with incorrect or missing race information. So why does this matter? So American Indian, Alaska Native populations in this country tend to be small, and as you try to get data down at the community level, numbers get pretty small pretty quickly. And misclassification makes those small numbers even smaller. Without accurate information, it's difficult to establish accurate baselines and measure change over time. And all this really obscures the true health status of American Indian and Alaska Native communities and ultimately contributes to that invisibility of Native people and data. So what can we do about misclassification? So we've identified kind of two general ways that you can address this issue. One is to prevent it from happening, and the second is to fix it after it happens. So how can we prevent it from happening? For one, there can be policy and system level changes. So working on policies that at a minimum add or require race and identity data collection in data systems, and also create opportunities to better collect data in ways that accurately reflect a person's identity. Another key issue is around training. So for providers and medical staff, how do we train these providers to both accurately and sensitively collect race information as they're documenting a particular health outcome or event? And similarly, how do we train funeral directors on the importance of documenting race as they're completing death certificates? Second way to address misclassification is to use statistical methods to fix miscoded race after it's happened. And one of the ways to do this is through a record linkage. So if you're not familiar with record linkages, it's essentially just the joining of one data set with another data set. And in the use case of addressing misclassification of American Indian and Alaska Native people, that first data set has accurate information on a person's status as an American Indian and Alaska Native person. And that second data set has the health data that you're trying to improve or analyze. So I'll spend a little bit of time talking about how this record linkage process actually happens. So this slide shows just an overall kind of schematic of linkage methods. I'd like to spend a little bit of time talking about how we obtain the American Indian and Alaska Native status data here at our organization. So we use what we call a Northwest Tribal Registry. This is a data set that we steward on behalf of the Northwest tribes. And it includes records of American Indian and Alaska Native people who have been seen at Indian Health Service, tribal, and urban Indian clinics here in the Northwest. We obtain this data under a data sharing agreement with the Indian Health Service, but we also obtain it with tribal approval through a resolution from our Board of Delegates. It's important to know that this data set doesn't include any health data, but it does include very highly identified information like name, address, social security number, and date of birth. So there, we also have to have a number of security precautions in place to make sure that we're properly protecting and stewarding that tribal data. Once we have this American Indian Alaska Native status data in hand, we're able to then go and conduct linkages with health data held by mostly state agencies. So you can see on the right-hand side of the screen a number of the systems that we currently link with on a regular basis. This includes things like death certificates, birth certificates, hospital discharge data, cancer and other disease outcome registries, and even things like trauma registries and violent death registries. Once we conduct the linkage, we're able to do a comparison of the race information in that health data. And then in cases where the information is correct for the people who have matched, we're able to get corrected data and then utilize that information for more accurate health statistics for Northwest tribes. So this slide goes into, again, a little bit more, a bit of a repeat, but a little bit more detail about our linkage methods. So first, we obtain that health outcome information like death certificates from state agencies. We then use probabilistic linkage methods to link that data with our Northwest Tribal Registry. Currently, we use a software called Match Pro as our linkage software. This is a software that is free and has been developed by the National Cancer Institutes to support cancer registry linkages, but it can be used for other probabilistic linkage applications. And we conduct linkages using identifiers such as social security number, name elements, date of birth, and address. Once we've completed the linkage, we destroy all of the identifiers provided to us by our state agency partners. What we do retain post-linkage is just a de-identified analytic data set that we can use for kind of more general health outcome analyses and surveillance. And one of our first steps is to look at those matched records and check to see if American Indian race is indicated for all of the records that match with our Northwest Tribal Registry. If a record that match doesn't have American Indian or Alaska Native race indicated, we're able to recode those records and therefore increase the ascertainment of American Indian and Alaska Native records in those systems. And then lastly, we utilize corrected data to analyze and provide data back to Northwest tribes. So I'll spend a little bit of time just talking through some of the kind of pre and post linkage results that we've seen from the linkages we've conducted over the last several years. And this slide just shows kind of a snapshot of what we've observed on average across data systems in our service area. So as I mentioned previously, systems like HIV surveillance and birth records, because they tend to rely on self-reported information and tend to have more opportunities for the person who is reporting information to confirm their racial and ethnic background. We found lower rates of misclassification in those systems. Kind of towards the middle, we've seen about 25 to 30% of American Indian Alaska Native records misclassified in COVID-19, cancer, and hospital discharge data, and then much higher rates of misclassification in systems that perhaps don't completely or accurately capture race and ethnic identity, and this includes things like general communicable disease data systems. This shows some of our misclassification findings for death records. So when we've utilized the pre and post linkage data to look at all-cause mortality rates, we found that the linkage corrections result in about a 10 to 11% increase in the estimates of all-cause mortality in Idaho and Oregon. Similarly, when we looked at the impact on cancer incidence rates, we found that for all invasive cancers, the linkage correction resulted in a statistically significant 32% increase in the all invasive cancer rate in Idaho. You can see that the effective misclassification varied a little bit depending on the type of cancer that we were examining. And then lastly, one of the applications that we've been focused on more recently over the last few years is really trying to improve the accuracy and completeness of COVID-19 data. So for one of the states that we partner with, we conduct quarterly linkages with their COVID-19 case surveillance data, and so far have linked with about 1.9 million confirmed and probable cases. Through those linkages, we've identified over 18,000 misclassified American Indian and Alaska Native cases. And correcting these misclassified records increased the identification of COVID-19 cases by almost 60%. One of the things that we do try to do is make our linkage efforts as mutually beneficial for tribes and state partners as possible. So we do share our linkage flags back with our state partners. And in this instance, the state does use the linkage flags to improve identification of American Indian and Alaska Native cases in their own systems. The figure shown here, the bar chart or the stacked bar chart, shows kind of how the original case, the misclassified cases were originally coded in the system. You can see that a really high percentage, 68.3%, originally just had no informative race information documented in the system. So in this case, the record linkages are actually working to improve the completeness of race and ethnicity data, or at least race data in this system, by filling in some of that unknown race information. So misclassification is one issue that's really important when conducting surveillance and just analyzing data on American Indian and Alaska Native people. But how data on American Indian people and Alaska Native people are reported also has a big effect on estimates of disease burden for these communities. And a really key consideration is how data on multiracial people are reported out. So based on US Census data, we know that here in the Northwest and nationwide, over half of American Indian and Alaska Native people identify as more than one race, and a sizable percentage also identify as Hispanic. So based on feedback from our tribes, we try to report when we're reporting statistics back to tribes, we use a very inclusive definition of American Indian and Alaska Native people. And this includes people who identify as American Indian alone, American Indian and Alaska Native in combination with other races, and also people of both Hispanic and non-Hispanic ethnicities. And this is quite different from how many state and federal agencies report out data on American Indian and Alaska Native people. What we've observed is state and federal agencies tend to report a very kind of limited, restricted definition by just reporting data on non-Hispanic, single-race American Indian and Alaska Native people. And this can have really significant impacts on morbidity and mortality estimates as shown here. And so what this slide is showing is basically, if you compare that very restricted definition used by many state and federal agencies to a more inclusive definition, your estimates of something like all-cause mortality can change by almost 50%. So this is a huge consideration in addition to misclassification when reporting data on American Indian and Alaska Native communities. So I'll spend a little bit of time just talking about some of the strengths of this approach. We hope that this work that we've been doing at the direction of Northwest tribes has increased access and availability of accurate health data for these tribal communities. This work really improves the representation of American Indian and Alaska Native people in data systems. For us, this means that we have more confidence in the accuracy of data that we report to Northwest tribes. It really increases our ability to calculate more stable rates and trends. And as I mentioned before, it's an opportunity to partner with state systems to improve the quality of their data. These methods are very replicable for other tribal jurisdictions. So if tribes want to conduct record linkages with tribal enrollment data, or also other tribal epidemiology centers are working using similar methods as us to conduct record linkages with state systems in their areas. The methods are, again, just very replicable and can be used in a variety of settings for tribal communities. And all this ultimately results in better data for public health decision-making and resource allocation. There are some important limitations to our approach. And one of those key limitations is that the data that we use for the Northwest Tribal Registry, we know it's not fully representative of the Northwest American Indian and Alaska Native population. So based on comparisons we've done of the distribution of records in the Northwest Tribal Registry to estimates from Indian Health Service and the US Census, we estimate that the registry captures about 70 to 80% of the Northwest American Indian and Alaska Native population. So who's missing from our data set? So we know that tribal members who are eligible but haven't accessed healthcare within the Indian health system aren't represented in our data. American Indian and Alaska Native people who aren't eligible for services but identify with a particular tribe wouldn't be represented within the data. And then finally, members of non-federally recognized tribes wouldn't be included in our data. There are also a few critiques of kind of just utilizing record linkages to address this issue of misclassification. And I think one of the most important ones is, again, that kind of conflation of a political status with racial and ethnic identity. So what's important to know about the Northwest Tribal Registry that we use is the data set has nothing about a person's race, racial or ethnic identity. It is solely an indication of a person's political status as a tribal enrolled member or a tribal descendant who is eligible to obtain services through the Indian health system. So again, we don't know anything about how those people self-identify in terms of racial and ethnic identity. We're just assuming that they are American Indian and Alaska Native because they have this eligibility for services through the Indian health system. So this is one of the kind of problematic pieces of record linkages. And it's related to the second bullet point about the limited ability to account for and describe complex identities. One of the issues we are also aware of is that most of the data that all of the data that we use, we apply record linkages to. These are all of our numerator data that we use to calculate rates. And we tend to rely on population estimates produced by the US Census Bureau for our denominators. And we know that those denominator data aren't being corrected for misclassification. So that's also kind of an inconsistency and a bit of a critique of record linkage methods. So I'll end my talk today just talking about the kind of now what. So over time, we've been able to really gather a large amount of information through our record linkages. And I want to spend a little bit of time talking about how we get this data back out to Northwest tribes. So we report back data in a number of ways. For one, we produce state and regional reports and community health profiles that provide a very comprehensive view of the health status of American Indian and Alaska Native communities in our area. We also have these more focused topic-specific data briefs that report out data on priority issues, including data on opioids and drug overdoses, which has been a really persistent priority for Northwest tribes over the last several years. And then lastly, we also use the data to respond to data and technical assistance requests from tribes. So we receive a number of requests from tribes for more tribe-specific analyses. And these tribe-specific analyses are never made available publicly, just to respect tribes' sovereignty and sovereignty over their data. We only make these tribal-specific reports available directly back to the requesting tribe. Um, we also use our data quite a bit to support policy and policy development that our organization is engaged in. We use data to support grant writing and also for advocacy on priority health issues for tribes and our organization. One of the projects that we're currently working on is to develop a Northwest Tribal Data Hub through which tribes can more easily access the improved data generated through the data linkages I've described. So when fully developed, tribes will be able to access a comprehensive community health profile that utilizes the most accurate data we are able to find for their communities. So the image shown here is our draft logo for the Data Hub project. And I just wanted to point out kind of the centerpiece. It's a salmon, and the salmon actually has some neat features in it, like a pie chart in its eye. There's a scatter plot along its back and a survival curve towards its tail. We chose the salmon to include in the logo for a few reasons. So salmon are incredibly important to many Northwest tribes, cultures, and food systems. And their life cycle involves leaving the places that they're born to journey to the ocean. And in the ocean, they feed and grow on marine nutrients. Salmon then return to the places that they were born to spawn. And in the process, they bring back nutrients, which support new generations of salmon, the overall ecosystems of these mountain river systems, and also the communities that depend on these ecosystems. So part of the reason we chose the salmon is we recognize that tribal communities are often left disconnected from the information generated by their people. And health data often leave tribal communities, but rarely return to benefit tribes. So our goal and vision for the Data Hub is really to return that enriched and improved data to tribes so that they can use it for their community's benefit. And so it basically, we're looking at data as kind of following that same life cycle as salmon do. So I wanted to end just with acknowledging our tribes, our tribal leaders, delegates, patients, and families. Also want to acknowledge the Indian Health Service, our state health department partners, and other data sharing linkage partners. Please feel free to contact me at any time. Happy to talk about the work that we do. And yeah, I'll turn it back over to Heather to see if I can answer any questions.
Thank you so much, Sujata. That was so helpful and so inspiring. I love how you ended on the salmon. The salmon is getting a lot of love in the chat. People really, really were happy about that. And we're getting some questions about the process of creating the salmon logo. Do you want to? I'll go back to the other questions in the chat, but who created the salmon logo? It's so cool. And we have actually quite a lot of questions about that in the chat.
Yeah, I am also, I don't consider myself a particularly creative person, but kind of the idea of the salmon really originated. We hired a Data Hub outreach manager a couple of months ago. And one of the first things I asked her to do is, can we create a great logo for the Data Hub? And through some brainstorming sessions with our team, we kind of settled on the idea of the salmon, and then in collaboration with our communications department, I have been working on different iterations of the logo. So we're really excited about it. We really hope it resonates with the Northwest tribes and that they're able to see kind of this journey that our data are taking reflected in the journey that salmon take.
That's so cool. Thank you so much. We have lots and lots of questions in the chat, and we also have Dennis with his hand raised. So let's start there. Hey, Dennis, how are you today?
Doing great. It's good to see you, Heather, and hey,
Yeah,
everybody.
good to see you too.
Uh, Likewise, sorry my camera's not on. I'm
No
hosting at
worries.
the moment,
No
but
worries.
so thank you very much for the presentation. It's wonderful to hear. Great information, and I love that you and the group have taken basically a chance to try something outside of the norm because they say to do what you know you have to do what you haven't done before to get what you haven't gotten before. So kudos for that. Um, I apologize in advance. This is a bit in the weeds. I'm an epidemiologist as well, so this resonated really strongly. Answer this in any way you'd like to. I want to ask about how you handle weighting the linked data within your data sets. Because you're going from population data and then you're going over to health data and how that weighting might apply. So that was one. Second was, are you seeing a decrease in the amount of in the number of things you have to suppress? That's just a very basic one, hopefully so. And the third one is I saw a lot of incidence data, which is excellent to have. I was also curious if you had more prevalence data, so things like screenings and other risk factors, other behavioral things of that nature, and how that might have benefited over the long term, so you can trend things year over year and see how things are working within the communities, because that is also, I would find really helpful. I'll stop there. Thank you.
Sure. Thank you for those questions. So I think my first response will hopefully address your first and third questions. So almost all of the data that we've linked with are considered like census data. So things like death certificates. We know that things like cancer registries try to ascertain all of the cancer incidents that happen within a jurisdiction. And same with communicable disease registries. We have never, to my knowledge, we have never linked with survey data such as BRFIS or PRAMS or things like that, where definitely weighting would come into more of an issue. And those types of surveys are also more often used to conduct those or calculate those prevalence estimates. Part of the reasons that we have never explored those possibilities is my understanding is the direct identifiers that we need to use for linkages are just not as readily available for conducting linkages. So it's just something that we haven't explored yet. We've tended to, we're a pretty small team, and so we've tended to prioritize data systems where yeah, we're able to just have the identifiers to link with and yeah, that are more of a population kind of census type data systems. To your question about weighting, we don't currently use any weighting methods. The probabilistic linkage software that we utilize does use weighting in terms of identifying potential matches, and it does that by calculating the probability of whether there's a match between the two data systems and that the person is the same between the two data systems. So my understanding and of the record linkage methods is the stronger identifiers that you have, the more likely you're able to identify people who match between the two systems. So I hope that somewhat answers your question, Dennis.
That did excellently. Thank you so much for your time and your presentation and your work. And please keep it up. I'm one of those lovers of the salmon, for the record. Absolutely. Please continue and let us know. Can't wait to hear the cool things you report out.
Thank you.
Great to see you, Dennis. And those are fabulous answers. Thank you so much. I really appreciate it. One question from the chat that we're getting over and over and over, actually two questions from the chat, and then we'll head to Mish, is the first question from the chat is, do you have any information, you may not from the purpose of your work, but do you have any information about the relative sources of the incorrect like the misclassification? You know, is it the way that they made the survey? Is it, you know, it was left off? And then the second question that's getting asked a lot is, how do you feel about matching someone to their American Indian or Alaskan Native status, given the possibility that they may have intentionally left it out in that other context or that other medical setting? So those are two that are coming up a lot in the chat.
Sure, I'll try my best to answer them.
Of course. Thank you so much.
Oh, sure. So for the first question around kind of the causes of misclassification, that's something that we haven't been able to really delve into too much. I know there was some really great work done by the National Council of Urban Indian Health that looked at specifically misclassification in death certificates. And what they did was talk to funeral directors and coroners who are and people who are involved with filling out death certificates, and try to understand why misclassification might be happening. What's interesting about death certificates is it's usually a next of kin who's reporting their loved ones' race and ethnicity information. So why is why are we seeing, even though it's relatively low, why are we seeing a misclassification? And from what I remember of that report, it kind of comes back to this more global issue of people just not feeling comfortable asking the question, or having support in asking the question in a sensitive way. And especially if you're thinking about a person's death, or if a person is involved with a traumatic accident and emergency department, is race and ethnicity at that point really important to get the person the life-saving treatment that they need. And so it's issues like that from what we know, and this is more from the literature. We also know, I think it comes down to, again, just how comfortable are people disclosing their identity. And what we've heard more when we've talked about misclassification with tribal communities, we've heard repeatedly multiple instances where either a person assumed their racial background and they didn't have that opportunity to correct that information, or people withheld their racial information just because they've had bad experiences of discrimination in receiving care. So this question of how do we kind of unlock and address these issues, I think there's more work to be done in those areas to really understand. And then the second question around how do I feel about correcting a person's race? I feel conflicted at times, and I think the work does kind of make me question. I mean, what we hold in our organization is that a person's self-reported race is the gold standard, but we're correcting people's race, and we don't know how those data were often collected, whether it was the opportunity for self-report or some other way of collection. So yeah, I often feel conflicted. What I fall back on is, for one, I mean, when we're reporting back data, it's always at a aggregated community level. And so when we think about the opportunities to benefit tribes and allow them to advocate for the resources they need for their communities, I'm hoping that kind of balances that more personal issue of maybe not respecting how a person self-identifies. So it's something I think about a lot, and I don't think I have the best answer for it yet.
Well, it's really interesting to hear the pros and cons, because of course there are pros and there are cons. And I just want to ask a follow-up, Misha. I'm so sorry. We're going to get to you in one second, because I think I misunderstood something you said based on your answer to that, Sunita, which is, sorry, Sujata. You can tell that I have had very severe food poisoning this week.
Oh no, oh no.
No, it just means my brain's not working correctly. So in the misclassification matching work that you do using Match Pro, if you change somebody's race from maybe missing to American Indian, Alaskan Native, do you only supply the data that goes with that change to anybody outside of the tribe itself in an aggregate way?
So when we're reporting, when we get the data back from the linkages, we use it for a number of levels of analyses.
Okay.
So when we're reporting state and regional data, we don't don't reply. We're not just reporting data on specific tribal communities. We never identify tribal communities publicly in our data, but we just look at within a state what's happening among American Indian people in that state. And especially for our policy work, that has been very helpful for them to, for the Northwest region, to advocate using that information. When it comes to tribal data, yes, we're able to provide, again, aggregated information back to the tribes, but at a more granular geographic level.
That helps me so much understand. I did have a misunderstanding in my mind. So thank you for clarifying that. And thank you for your patience, Mish. Hey, it's great to see you. How are you? Mish? I think we might be having a microphone issue. Let's see if we can hear Mish. Right now you're muted. Your mic is off. Now your mic is on. But we cannot hear you. I'm not the only one, right? Sujata, can you hear me? Okay.
No, I unfortunately can't.
Okay, well, we'll go to a different question. And you, oh, Misha has her mic open again. Okay, we're gonna go to more questions from the chat while we see if we can get Misha's mic fixed. And let's see, do you know if there's other tribal epicenters that are working on this problem as well in similar or different ways?
Yes, definitely. I know the California Tribal Epicenter has been working on this issue. We've provided technical assistance to the Great Plains and Great Lakes tribal epicenters as they're kind of embarking on their linkage work. So it is kind of spreading in terms of just like a method that we use in tribal epidemiology practice. I also want to mention individual tribes have definitely conducted record linkages using their enrollment data. So that's also happened.
Yeah, cool. That's really good to know. And do you have, and again, this might be outside of the scope of the work that you're doing, so don't feel like just because we ask a question, you have to know the answer. But do you know what the linkage work that you've been doing, what effect that's had on the perception of disparities and health equity?
I can speak to just based on the data we're able to report. Again, we feel more confident in the data that we report back to tribes, but especially through our partnerships with state agencies, we've really tried to build awareness of this issue and really challenge those agencies to consider how not only their support of this work, but consider how they're reporting data on American Indian communities more broadly, but also how they serve, they're meeting their obligations to the tribes in their areas. So I think there's more awareness now, and definitely when I've heard really amazing Indigenous practitioners talk about the invisibility of data, I think some of the linkage work is now cited as a kind of a best practice that if agencies have the capacity to use it, that is a recommended practice when working with tribal or American Indian Alaska Native data.
Okay, that's great. Thank you. Oh, we have, I think we have Mish on a phone now. Mish?
I'm so sorry. My camera is not working today. I apologize.
No worries. How are you?
Thank you for the salmon. I am well, thank you. I really appreciate, I'll be fast since the end, everything. It was really helpful, and I am so excited to see that salmon fuller in. I had a couple of questions. One is, I had the benefit of attending a National Academies of Health 2-day workshop on data and the capture of data. And Yosef Iracheta from the Native Biodata Consortium, talked a little bit about how when the data goes back into kind of an open data framework, some of the challenges, because you can follow those breadcrumbs back even when you aggregate it. That was one of the things he brought up that I want to know. Are you guys following the tribal data sovereignty guidelines? The second piece of that is he commented on the large categorization of attaching Hispanic or not Hispanic to Native data at the exclusion of other ethnic or racial identifiers, especially in areas such as the Pacific Northwest that have cities with a lot of Native populations that are mixed race who come from outside of that region. And so they have different tribal rules. And I bring that up for the third part of the question when someone asked why someone might not put it in there. So in New York, I participated in something called All of Us, and it's looking at your genes. And because I'm listed as white, Native, and Black, it triggered a stop for me in the survey, and it asks your specific tribe, and it won't let you continue because some of the tribes don't actually allow you to give some medical or genetic data. And so I was wondering if that is something that you have embedded in the work that you do, those structures, and if you're working with with them on some of those things, because I loved how you answered the question with the conflict, but it didn't necessarily answer my question of, is it embedded in your process, in your practice? Thank you so much for answering my question. I'll mute myself now.
Sure, and if I don't answer a part of your question, please let me know. When it comes to data governance and data, kind of the rules we have around data within our organization, any data that we have at a tribal or tribal area specific level, we never release that to anyone outside of that specific tribe unless we get written permission from that tribe to disclose it to a third party. So that is, and that includes even if the data comes from a state agency or the data is actually coming to us from Indian Health Service, we still follow those rules because we are first a tribal organization, and the tribes again own all of the work that we do. So we hope that that practice supports tribal sovereignty. In the Northwest, there have been a lot more conversations on how do we operationalize principles of data sovereignty. And it's really heartening to see that some of the state agencies in this area are trying to figure out how do they put some similar practices in place to protect tribal sovereignty. Those conversations are ongoing, and I would say it's for us to also continue the conversations with the Northwest tribes as their priorities and kind of takes on tribal sovereignty change. It's for us to really hear from them and update how we're actually doing our public health and epidemiology practice. That was a very general question to your very specific. That was a general answer to your very specific questions. Did that somewhat answer them?
Yeah, it was. No, that was a very good answer. What I heard was you don't share out without permission, and that while you may not have it in the process, it's something that you're beginning to look towards, especially in light of big data, like we talked about. Those are both excellent. Thank you. They're a great answer. When you're trying something new, you have to figure it out. I really appreciate you answering that for me. Thank you so much.
Great question as always, Mish. And we need to leave it here. We're even a little bit over time. So thank you for those who could stay. And a huge, very sincere community-wide thank you to Sujata. I really, really appreciate that you could come and share your time with us today. It meant the world. We know how important the work you're doing is and how busy you are, and to take a whole hour of your time to connect with us. Really meant a lot. And you can see in the chat that it's not just me that feels this way, it is everybody here. I really appreciate it. And I know that there'll be lots of people who couldn't come today that will rewatch the video and learn a lot as well. So thank you for coming. I really appreciate it. And to everybody else who came and hung around for this hour, I really, really appreciate it. We are taking a couple of weeks off. We are going to be back on Friday, January 12th. And we will make sure that you all get updated calendar invites that have the correct time zone in them so that you know that it starts at noon Eastern time. It looks like there was a couple of time zone mistakes still hanging around out there. So 12 noon Eastern time is always the time for Talking Data Equity, and it happens most Fridays at the same Zoom link, and we will resume on Friday, January 12th. And in the meantime, if you want to enjoy some of our archived recordings, there is the link to the recordings. All right. Thank you so much for coming, everybody, and take really good care of yourselves and each other. Bye, everybody.